Welcome, everybody. This is the pulmonary rehab exercise training module, and my name is Eric Ostrowski. I have been in the cardiopulmonary rehab field for about 10 years now, worked at a few different hospitals, and I am a registered clinical exercise physiologist. I do have my CCRP and my master's degree is in exercise physiology. So before we get started, I want to give a special thank you to my co-contributor, Kim Eppen. She was absolutely instrumental in helping me prepare this presentation and setting it up in a way that we hope is going to provide a lot of value and be the most impactful and useful for your program and your staff. So without further ado, we will get going. So the objectives today, there are 4 of them. The first is to understand, for you to understand the extent to which shortness of breath impacts patients with chronic pulmonary disease. We certainly hope by the end of the program or the end of the module today, you are able to describe the adaptations and potential benefits that occur with exercise training on patients with chronic pulmonary disease. We certainly want you to be able to demonstrate your knowledge of exercise testing and programming principles for patients with chronic pulmonary disease, and be able to develop a safe and effective exercise prescription for patients, your pulmonary rehab patients, using not only evidence-based guidelines, but best practice recommendations. A brief outline of the content we'll be going through today. The first, we'll start off by talking about the factors that contribute to exercise intolerance, moving on to the training adaptations that we hope your patients are able to experience with a quality exercise program. Then we'll move into the importance of an exercise assessment. We'll define why an assessment is important, what all encompasses an exercise assessment, and go into depth on how to perform and get the most out of the exercise test that we review. That'll lead into exercise prescription, where we'll review the different components of an exercise prescription with a decent amount of time spent on how to come up with an appropriate exercise intensity. We'll also touch on interval training, inspiratory muscle training, and briefly discuss home-based pulmonary rehab as well. We'll then move into safety considerations for our patients, various comorbidities that our patients may come to our programs with, and accommodating factors that we need to consider when developing an exercise program. And finally, we'll wrap up with exercise training considerations for what I've called other diagnoses. So these are patients that don't fall into the traditional COPD category. So that would include patients with asthma, pulmonary arterial hypertension, interstitial lung disease, cystic fibrosis, and post-lung transplant patients as well. So let's get to it. So there are a variety of factors that contribute to exercise intolerance in our patient population. The primary one, obviously, the ventilatory constraints that our patients experience as a product of their chronic disease. We know that obstructive disease is really an issue with airflow limitation, whereas restrictive disease is really more of an issue with air volume limitations. Certainly, our patients can experience or have some gas exchange abnormalities. They may have gas exchange abnormalities. So oxygen and carbon dioxide may not diffuse across that alveolar membrane as efficiently as an otherwise healthy individual. Our patients are very deconditioned. They may be experiencing a variety of cardiac or vascular dysfunctions that contribute to exercise intolerance. They have reduced muscle strength, or mechanical disadvantage of their muscles, certain muscles, to make exercise more difficult to be able to perform, and certainly become more short of breath. A lot of our patients experience airway inflammation, making it more difficult to certainly get air out of their system, making it a lot more challenging to breathe and making exercise a lot more difficult. And all of these things contribute to the anxiety that a lot of our patients experience during, especially the initial components or the initial part of our exercise program. So when our patients have lung function impairment, that's going to lead to shortness of breath. We see that all the time. That shortness of breath will lead to reduced physical activity. And when patients are short of breath, they just tend to not be as physically active because it's uncomfortable. And as an individual reduces the amount of physical activity they perform, they become deconditioned. And when you're deconditioned, you have even greater shortness of breath. So this spiral here, we call it the dyspnea spiral. Our role in pulmonary rehab, or one of our primary roles, is to help patients break this spiral. And we do that by focusing on the very bottom component there, that reduced physical activity component. So we want our patients to be more physically active so they don't become as deconditioned, so they don't experience as much shortness of breath, and ultimately have a higher quality of life and from their disease. So there are a variety of training adaptations we hope a patient can experience by participating in a pulmonary rehab program. And the first are peripheral training adaptations, followed by improved motor recruitment efficiency. Our patients are able to, as you become more physically active and your exercise tolerance increases, you have improved motor recruitment efficiency. There's the improved breathing strategies that we review with our patients, and the movement strategies that we review with them can certainly help them increase their ability to perform exercise. The more comfortable patients get with the exercise they're performing, the less shortness of, the more desensitized they become to that shortness of breath, and the less anxiety they experience as a result. And certainly less anxiety will lead to improved confidence and the patient's ability, their belief in themselves and their self-efficacy to continue performing physical activity and exercise at a level that improves health benefits on their own. So not only do we hope that our patients, experience improved exercise tolerance, but also they have an increased ability to perform their activities of daily living, so they can continue to live functionally independent lives. They will have reduced shortness of breath, improved quality of life, reduced depression and anxiety, and ultimately, what we all hope for is fewer exacerbations and hospitalizations. So why should we do an exercise assessment? The primary reason is to establish a functional baseline capacity. By performing an exercise assessment on a patient, it gives us an idea where the patient starts off physically, functionally, so that we can then develop an effective individualized exercise prescription for them. It allows us to develop patient-specific goals. It allows us, an exercise assessment will allow us to evaluate the potential need for supplemental oxygen or an increased level of supplemental oxygen, give us an opportunity to look at their medications and see how they perform physically, to get an idea of perhaps maybe how well their drug combination, their medication combination is working for them. Certainly during an exercise assessment, we'll have the opportunity to notice whether a patient experiences exercise-induced bronchospasm, and really just observe for any signs of exercise intolerance. And certainly the assessment, not only the exercise component, but the medical history review part allows us to evaluate whether the patient is going to be safe performing the exercise at the intensity and the level that we would hope for them during our program. And certainly an assessment is a required component of a pulmonary rehab program, not only from CMS standpoints, but also from a program certification standpoint as well. So there are a variety of exercise endurance tests that we can perform with our patients. The first being the cardiopulmonary exercise test, which is a maximal treadmill or cycling test. And the point of these tests is to directly measure the maximal or peak volume of oxygen consumption of our patients. We can also do clinically graded exercise tests, of which the treadmill is certainly the most common modality. And this is an individualized submax or maximal test with a VO2 peak estimation. And then the field tests, the field walking tests, are the ones that we're most commonly concerned with. These are the tests that we most commonly see in our programs, that we most commonly use. So the 6-minute walk test is a perfect example. It's one that we most often use, and it's a submaximal walking test. It can be maximal for some individuals, and the 6-minute walk test is not the only field walking test. We'll go over a few other ones here in just a minute as well. Before any exercise test is performed, it's important to take into consideration the contraindications of an exercise test. So these are a list of the absolute and relative contraindications to performing an exercise test. So be sure you familiarize yourself with these. Patients that have any of these medical conditions, we need to be extra careful, completely avoid doing an exercise test with, or be very, very cautious of performing an exercise test if a patient's fall into one of these categories. So the 6-minute walk test is a field walking test used to quantify functional exercise capacity. The primary outcome, as most of you know, is the maximum distance a patient walks in 6 minutes. The biggest advantage to a 6-minute walk test, it's very well validated in the chronic lung disease population. It's very easy to administer, minimal resources are required. It's very easy to train your staff to perform these tests. It's well tolerated by the patient. The fact that the patient can slow down or take a break as often as they'd like during the test really makes it so that the patient can, the majority of our patients can perform the test. It adheres to the principle of specificity, which is the fact that we're measuring an individual's functional capacity over through a test that is an activity that they perform every day, which is walking. So it's very easy to perform, and allows us to assess improvement over time. So we know by doing the 6-minute walk test before the program, and then comparing the results to the 6-minute walk test after the program, we can assess whether the patient improved their functional capacity. What's an important note here is that what we consider the minimal clinically important difference between the pre and the post 6-minute walk test distances is 30 meters. So the idea here is that if a patient walks at least 30 meters further on their post test than their pre-program test, that is a meaningful, clinically significant difference in walking distance. And of course, the 6-minute walk test can be used to satisfy your performance measure reporting requirements for functional capacity if you are an AACVPR certified program. So just touching base a little bit on these other field walking tests. There's the incremental shuttle walk test and the endurance shuttle walk test. The incremental shuttle walk test is just a symptom-limited walk test that simulates a symptom-limited cardiopulmonary exercise test, measures walking distance over a marked course of 10 meters, and the patient stops when they can no longer keep up with the pacing timer. There's an audible pacing timer in this test that incrementally and gradually increases pace, and as soon as the patient can't keep up with that timer any longer, the test is over. And the results of this test correlate well with maximal oxygen uptake, or maximal VO2. There's also the endurance shuttle walk test, and that's to perform this test, you essentially have to perform the incremental shuttle walk test first, and you take 85% of the walking speed that the patient, maximal walking speed that the patient achieved with the incremental shuttle walk test, set the pacing timer at a constant speed or constant pace, and then the patient will just continue walking at that pace until they can no longer keep pace with the timer. And this correlates really well with exercise endurance. So these are just some other options. Here is the technical standard on how to perform all of these tests. So you can feel free to just go to Google, pull up this Google Scholar, pull up this paper, and it will give you directions on how to perform all of these tests. I would highly recommend, I've incorporated this article into a standard operating procedure and use it to train my staff on how to perform the 6-minute walk test. So it's a very good paper to have on hand. So some other exercise tests to consider. So we reviewed endurance exercise tests, but we know that cardiorespiratory endurance isn't the only function of fitness and health. So there's also muscular strength and endurance is extremely important, as well as we'll discuss further in the exercise prescription section of this presentation. But we can do a 30-second chair stand test, is a very well validated test that looks at lower body and leg strength and endurance. The 30-second chair stand test, as the name of the test implies, takes 30 seconds. It is just essentially how many times the patient can perform sit to stands in a chair without using their arms as assistance, how many times they can do that in 30 seconds. There's also an 30-second arm curl test, which is an upper body arm strength and endurance test. So men use an 8-pound dumbbell, women use a 5-pound dumbbell, and how many arm curls they can perform in 30 seconds can be benchmarked against similar gender and age match norms. Hand grip dynamometer test. If you have a hand grip dynamometer, you can look at upper body and arm grip strength to give you an idea of upper body strength. And then there's a timed up and go test too that can help you determine an individual's, if they're at risk for falling. So if they're a high fall risk or just their general balance and their gait pattern. So this can be a great test to consider as well. Moving on into exercise prescription, there are we'll talk about, there's really 6 components of an exercise prescription. That includes frequency, intensity, time, type are the first 4. This is what ACSM and a lot of the literature refers to as the FIT principle, F-I-T-T acronym. But then there's also volume and progression are also components of the exercise prescription. And that is you'll often hear that referred to as the FIT-VP principle. And we'll discuss all of these components in greater detail. We're going to start a little bit backwards here with type in just a second, but let me explain a little bit more about what these are. So frequency is how often a patient exercises. Typically, that's described in number of days per week that they exercise. Intensity is how difficult or physiologically challenging the exercise is. There are a lot of ways to express exercise intensity. We will spend the most time today talking about METs, RPE, and dyspnea. Although you see in the literature heart rate max, heart rate reserve, VO2 max, VO2 reserve. We'll touch briefly on what these are, but the most useful functions of intensity that you'll use in your program and probably are already using have to do with METs, RPE, and dyspnea. The time, it really refers to the duration of each exercise session. That's typically reported as minutes per session of exercise. And the type refers to the modality of exercise, the mode of exercise that they're performing. So, like I said, starting backwards here a little bit, what types of exercises are appropriate for patients with a chronic respiratory disease? Endurance, resistance, and flexibility exercises are all appropriate for this patient population. In terms of endurance exercise, the focus is on continuous rhythmic activities that involve large muscle groups. So walking, biking, swimming, rowing, stepping, arm ergometry, you name it. So any continuous rhythmic activities with large muscle groups encompasses the type of exercise for endurance. Resistance exercise, so strength building, muscular strength, muscular endurance building exercises. The recommended for this patient population is using free weights, resistance bands, or body weight exercises, and certainly emphasizing lower body and multi-joint movements. We'll talk about the importance of the upper body as well, and certainly flexibility exercise is appropriate for this patient population. Both static or dynamic stretching of all major muscle groups is appropriate. How many times per week should a patient with chronic respiratory disease exercise? For the recommendation for endurance exercise is 3 to 5 days a week. For resistance exercise, it's 2 to 3 non-consecutive days per week. And flexibility exercise, at least 2 to 3 days a week, even up to daily would be appropriate. An important note here at the bottom that I wanted to include was these numbers need to be considered as a combination of supervised and unsupervised sessions. So these numbers don't mean that your patient needs to be coming to your pulmonary rehab program 3 to 5 days a week and doing endurance exercise training. This means that if the patient's coming to you 2-3 days a week, that they need to also be incorporating unsupervised sessions or at-home sessions in addition to their in-center sessions to meet these recommended frequency guidelines. How much or how long should a patient with chronic respiratory disease exercise per session? Well, for endurance exercise, the recommendation is anywhere between 20 to 60 minutes of exercise per session. It is acceptable. I know a lot of our patients, especially when they first come into the program, aren't able to perform 20 consecutive minutes of exercise, and that's perfectly fine. Shorter intervals are okay, and interspersed with rest, and gradually building the patient up to where they can accomplish 20, 30, 60 minutes of continuous exercise is the ultimate goal. We'll talk about this a little bit more when we talk about progression, but shorter intervals are appropriate. For resistance exercise, it's same as for an otherwise healthy population. So this would include 8 to 10 different exercises focusing on all the major muscle groups of the body, 1 to 4 sets per muscle group, 10 to 15 reps per set. For flexibility, all major muscle groups, 30 to 60 second holds per muscle group, and 2 to 4 repetitions. Okay, moving on to intensity, we will start off talking about RPE. Intensity is certainly can be one of the more challenging exercise prescription components to adapt to your individual patients, because there are so many different options and patients are so individualized. So we will try and make this as easy and straightforward as possible. We'll talk in depth about RPE, dyspnea, and then METs as we talked about. So let's start off talking about RPE. RPE stands for rating of perceived exertion. And this is just a subjective exercise intensity scale where a patient rates how difficult, how challenging the exercise is for them, or the exertion that they're currently performing, how difficult that is for them. There are a couple different scales we use. I bet all of your programs are using one or the other of these scales. And the first one's the traditional Borg scale. This goes from 6 to 20, 6 being no exertion at all, 20 being maximal exertion. And then there's also the Borg CR10 scale, which is essentially the same scale as the 6 to 20. It's just been condensed down to a 0 to 10 format to make it a little bit easier potentially for patients to be able to indicate how challenging their exercise is for them. So the recommended intensity level, if you're using RPE to guide exercise intensity, with the traditional Borg scale, what you're shooting for is a 12 to 14. So the exercise that the patient is performing should be somewhat hard, in that somewhat hard range. If you're using the Borg CR10 scale, I know it's kind of tucked behind the other one there in the image, but the idea between 4 and 6, so it's moderately hard. And so these are the intensity levels that we want to have, ideally, our patients exercising at when they are in our programs, and even when they're performing exercise outside of our programs. So we can do something very similar to RPE, but use shortness of breath instead. So we can use a subjective shortness of breath scale. This is what's called the modified Borg scale for dyspnea. So once again, it's a 0 to 10 scale, nothing fancy, but it goes from 0 to 10, 0 being nothing at all, 9 and 10 being very severe, panic level, maximal shortness of breath. And to probably nobody's surprise, the recommended intensity level using dyspnea to guide exercise would be in the slightly moderate to somewhat difficult shortness of breath. So we know that patients are going to be short of breath when they exercise, certainly more so than they are at rest. That's just a standard physiological response to increased exertion. But we want to make sure that our patients, have, a moderate level of shortness of breath, and that it's not too severe. Certainly if you're getting numbers for your patients 7, 8, more, it's probably at that point would be a good idea to consider reducing intensity. So we can also prescribe exercise intensity with METs, and METs is metabolic equivalent of a task. It's an acronym for metabolic equivalent of a task. So it's really an expression of oxygen utilization and uptake. So METs is a function of VO2. It allows for comparison across individuals because it's matched to and standardized for body weight, takes into consideration of patient's body weight. So 1 MET equals 3.5 milliliters of oxygen per kilogram of body weight per minute. This number isn't too important. We'll try and stick with METs in our calculations here and the examples that I bring up. But just know that 1 MET equals 3.5 milliliters of oxygen per kilogram of body weight per minute. And a percentage of METs then can be used to prescribe exercise intensity levels. So the individualized target MET training goals for a patient have to do with prescribing exercise intensity at a percentage of a patient's observed or peak METs achieved during an exercise test. So we can, if we're using a treadmill graded cardiopulmonary exercise test, the recommendation is that whatever the peak MET level achieved during that test is for the patient, that we take approximately 60% of that, and that would be the starting exercise intensity in METs for that patient on whatever exercise modality you're having them perform. And then over time, you're progressing them to greater than or equal to 85% of that peak achievable MET level. If you're using a 6-minute walk test, which most of us probably are, the goal is to use you'll take 80 to 85% of the estimated MET level from the 6-minute walk test and start a patient's initial exercise intensity on whatever modality you choose at that MET level. And an alternative approach to this 6-minute walk test approach is to just take 80% of the patient's 6-minute walk test, of their average walking speed during the 6-minute walk test. So we'll walk through an example here, using METs from a 6-minute walk, derived from a 6-minute walk test, to developing an initial exercise prescription for a patient, or initial exercise intensity for a patient. So the example is determine initial exercise intensity in METs for a patient who walked 1,260 feet during his or her 6-minute walk test. So the first thing we want to do is convert the distance the patient walked in feet to meters. Most of us are probably measuring in feet, but there's probably quite a few of us out there that are measuring in meters. Here in the United States, we are measuring certainly in feet. And so 1,260 feet times the conversion factor, 0.3048 meters per foot, gives us a walking distance of 384.05 meters. The reason it's important to convert to meters is because we'll be using a ACSM metabolic equation here in just a few minutes, and it requires meters, metric numbers. So the second step is to convert meters per minute to get a walking speed. So there you have your 384.05 meters over 6 minutes. Gives you a walking speed of 64 meters per minute. Next, you'll convert the walking speed to a MET level. This is where you use the ACSM metabolic equation. And for your reference, you can find these in the ACSM guidelines for exercise testing and prescription 11th edition. But here is the equation. And what we ultimately do is we plug in our 64.0 meters per minute into the equation, do our order of operations, and we get 2.83 METs. So 2.83 METs is the result of the 6-minute walk test. So what we want to do then is use the MET level of the 6-minute walk test to determine a patient's individual initial exercise intensity. So here we'll use the 80 to 85% of their achieved MET level, which was that 2.83 METs. So we take 2.83 METs times 0.8, gives us about 2.2 METs, and this would be your starting exercise intensity using METs for a patient. Depending on how the patient does with exercise at 2.2 METs, you can certainly consider titrating their exercise upwards or even downwards if necessary, depending on the RPE or even dyspnea that they give you. So if you're using the traditional Borg scale, you can certainly adjust as is appropriate for each individual patient, their exercise intensity upwards or downwards until you get to that 12 to 14 in that traditional Borg scale of RPE. If you don't want to go through the equation, which you can still go through the equation to get precise numbers, and a lot of our EMRs or electronic systems will give us 6-minute walk test MET levels. But here's a handy chart that I was made aware of just recently, actually. And so this comes from the AACVPR Pulmonary Rehab Outcomes Resource Guide, or their outcomes toolkit. So you can find this in there. But using our example, if we look at the leftmost column, this is the distance the patient walked in feet during the 6-minute walk test. And our patient walked 1,260 feet, if you recall. So right about in the middle of those two numbers. And if we look all the way to the right-hand column, the furthest right-hand column of the chart is METs. And right in between that 2.74, 2.89 is about our 2.83, 2.82 maybe, METs. So you can use this as like a quick down and dirty conversion to help you realize, quickly how many distance or what, depending on what distance the patient walked, whether you're measuring in feet, converting to meters, or measuring meters, to get their starting MET levels. So we're not going to go into specifically how to prescribe exercise with these other methods, but I just wanted to make you aware of what they are, and you can certainly look up more information on how to utilize these physiological variables to prescribe exercise for your patients. They're just, certainly there's limitations with them. There's a certain convenience factor with utilizing METs, RPE, or dyspnea instead of these variables, but I just wanted to, I'd be remiss not pointing them out to you and explaining what they are. So we can prescribe exercise based on a percentage of an individual's heart rate max. So this is a prescribing exercise as a percentage of their maximal achievable heart rate, typically expressed in beats per minute. And when I say maximally achievable heart rate, I mean the maximal heart rate that they achieve during a progressive exercise test, not using some kind of 220 minus age equation. There's a lot of issues with that in general, but the primary one being that heart rate is just an extremely individually variable measure. And so it can change very widely from one patient to another. So you have to take that into consideration. We can use heart rate reserve, which is just the difference between the individual's maxing and resting heart rate values. Ideally, once again, those are directly measured. So directly measured resting heart rate compared to directly assessed maximal achievable heart rate, and then prescribing a percentage of intensity based on that. And we can do essentially the same thing we did with heart rate, with percentage of heart rate max and percentage of heart rate reserve, as we can with volume of oxygen consumption. So we can look at someone's VO2 max, take a percentage of that, and prescribe exercise. That's typically expressed in milliliters of oxygen per kilogram of body weight per minute. And then we can also do a VO2R. So that's where we take the difference between an individual's maximal achievable VO2 and their resting VO2, and prescribe exercise based on a percentage of that. So these can be very valid and very useful ways to prescribe exercise, but there's just a certain level of care that needs to be used when using these. And you do, I would argue, lose some convenience of using like an RPE or a MET instead. The volume of exercise, you'll see this a lot in the literature. A lot of research literature will look at the total volume of exercise that a patient performs. And to calculate the volume of exercise, it's really the frequency that a patient exercises multiplied by the intensity that they exercise, multiplied by the time per session that they exercise. So that would be number of days a week times whatever intensity level, usually it's a MET level, times however many minutes they exercise per session. And you'll typically see this expressed as MET minutes per week, or MET hours per week, or even kilocalories per week as well. And like I said, it's a standardized measurement typically used in research, but there are some exercise prescription recommendations that you could consider utilizing exercise volume for. So in an otherwise healthy population, ACSM does recommend a 5 to 10% increase in exercise volume per week for a healthy population. So this may be appropriate to use with your chronic lung disease population as well. There is a recommendation to strive for between 500 and 1,000 minutes per week. for just general health and wellness. And so if we just practice calculating this real quick, it's really straightforward, as you can see. If a patient's exercising 3 times a week at 3 METs for 60 minutes each session, that's just 3 times 3 times 60. So this patient would have an exercise volume of 360 minutes per week. So this patient is not meeting the minimum required for an otherwise healthy population of 500 MET minutes per week. And so this, I think, example really does a good job of illustrating the importance of making sure that our patients are not only exercising in center with us the 2 to 3 days a week that they do, but also at home as well. So the progression recommendation for endurance exercise is to initially focus on increase in individuals' duration of exercise per session over their intensity initially. So an initial goal, a really great initial goal for our patients would be to increase their exercise 5 to 10 minutes per week during the first 4 to 6 weeks, and then titrate the exercise prescriptions to their symptoms, to their dyspnea that they're giving you, the RPEs that they're providing you, or the calculated MET levels that you do with them. Remember that shorter intermittent sessions may be necessary initially. A lot of patients, like I said, can't come in and exercise 20 continuous minutes before resting. That's completely fine. But these patients could very well benefit from interval training, and we'll have a whole slide on that here in a second. Doing intervals, we're allowing the patient to just exercise for as long as they can initially, resting, going for as long as they can, resting, and then gradually decreasing the number of rest periods they have, increasing gradually the time for each interval can be very beneficial. For resistance exercise, the weight or the resistance and the repetition should be increased as strength increases. Monitor the individual's RPE, fatigue, and pain levels, and increase the weight of the exercise as soon as the patient can easily perform sets when they're giving you an RPE of less than 13. So when they start telling you it's not somewhat difficult anymore, it's a great opportunity to increase some of the other variables, whether it's the weight or the number of sets that they perform. So interval training, like I said, should really be considered to use as an option for patients that can't perform continuous exercise because they're either too short of breath, too fatigued, too deconditioned, or they have other symptoms that limit the length of time that they can exercise before they require rest. It's important to note that both interval and continuous endurance exercise training appear to be equally effective in patients with COPD. So for symptom-limited individuals unable to tolerate moderately high intensity continuous training, strongly consider interval training as an alternative. An initial interval goal should be around 5 or so minutes, continuous without resting, and then over time, gradually increase the time of each interval and decrease the frequency of rest periods. Like I said, both interval and continuous endurance training modes elicit similar effects on exercise capacity, health-related quality of life, and symptoms. So this is still a very valid training method with this population. So interval training, not to be confused with high-intensity interval training or HIIT training, HIIT training. High-intensity interval training is just an exercise protocol involving frequent, short, alternating bouts of exercise and rest. Like I said, can be as effective alternative to continuous moderate intensity exercise for appropriate patients. I say appropriate patients because it utilizes high intensity exercise and not low to moderate. The training effects are very similar in magnitude to continuous moderate intensity exercise, and often patients can achieve those effects, those training effects, with less overall exercise, less minutes of exercise, because they're exercising at a much higher capacity. So typical intervals look something like between 30 seconds and 2 to 3 minutes each. That really is highly dependent on the patient, and the intensity of each of those exercise intervals are very high. So we're talking 80 to 100% of their peak or maximal achievable VO2. So these are very high intensity intervals. That's why the time of each exercise interval is so low, and then the patient would rest. So high intensity interval training can certainly be utilized for specific patients. There is a significant amount of research discussing and describing the efficacy of the training. So certainly you're welcome to research more into that, but it could be very appropriate for certain patients. All right, so moving on to inspiratory muscle training. The goal of inspiratory muscle training is to improve the strength and endurance of the respiratory muscles in patients with documented respiratory muscle weakness. So patients that are cachectic or have long-term corticosteroid use often have respiratory muscle weakness, where inspiratory muscle training can be very beneficial to them. But in patients with pulmonary disease that have mechanical dysfunction, so patients with COPD, we know they have mechanical dysfunction of the muscles. It's not necessarily respiratory muscle weakness. Improvement in muscle strength is not likely to occur in these patients, so certainly keep that in mind. And there's a good quote here from one of the guidelines, is that, you know, whether more specific inspiratory muscle training using restrictive breathing devices enhances outcomes is controversial. Some studies have demonstrated a reduction in dyspnea, increased walking distance, and improved heart-related quality of life. So inspiratory muscle training can be very beneficial to our patients. Certainly it's beneficial for patients that have respiratory muscle weakness, but if they don't necessarily have a condition or suffering from respiratory muscle weakness, you can consider adding it as an adjunct to traditional endurance and strength exercise, but certainly don't limit the amount of endurance training or resistance training recommended exercise to fit in inspiratory muscle training if it may not have as many benefits as traditional endurance exercise training. A note about home-based pulmonary rehab. So currently there's no evidence-based guidelines for pulmonary rehab at home. There is certainly a lot more research coming out advocating and demonstrating the efficacy of home-based pulmonary rehab, or even hybrid rehab programs that are partially center-based, partially home-based. There aren't any, though, but even though that research is coming out, there's not a consistent evidence-based guidelines for how to conduct pulmonary rehab at home. Clearly, the key to this, though, is we want to make sure that patients are safe to exercise at home, safe for unsupervised exercise. So just some general recommendations if you're utilizing home-based pulmonary rehab or a hybrid type pulmonary rehab. It's recommended to complete the health and physical and your functional capacity assessments first in person, so that you can see what functional limitations the patient has, lay eyes on the patient, ask them, be able to ask them questions and perform that exercise assessment in person can be extremely valuable. Certainly, if a patient's not able to walk at least 50 or so feet unassisted or without a usual walking aid, should be referred to physical therapy before they begin an in-person program. We want to make sure that they are physically capable of exercising at an intensity that will elicit health benefits for them when they're at home and unassisted. Certainly, if we're doing a home-based pulmonary rehab program, we still need to encourage exercise and lifestyle modifications. So we still need to be doing our traditional education with the patients. How you see fit to deliver that education is kind of still up to you at this point. Making sure that we're utilizing that initial in-person exercise assessment time to evaluate how an individual and how much an individual maybe desaturates on their SpO2 levels will give you a good idea in helping to determine whether a patient needs to increase their supplemental oxygen use at home and in your program. And so it can be very valuable. Making sure that we're still teaching in return, doing teaching in return demonstration of proper use of inhaled medications, especially those short-acting bronchodilators that could, those rescue medications. And just recognize that not all patients will be appropriate for home-based PR. There's some patients that are very, functionally independent. Maybe they're on a much lower level of oxygen. They might be a really great candidate for home-based pulmonary rehab, but that decision should be made on an individual patient basis. So moving on to some safety considerations and comorbidities. So we will encounter patients that a majority of our patients don't just have pulmonary disease. They have some other diseases as well, most commonly cardiovascular disease. So if we might have to consider increasing blood pressure monitoring on our patients, or on the patients that have cardiovascular disease. We might have to incorporate some fluid or weight management education in our heart failure patients. We might have patients with arrhythmias that like AFib that could benefit from some telemetry monitoring. So making sure that we are taking into consideration the individual factors of these other comorbidities that patients come into our programs with. Patients with osteoporosis need to are at higher risk for vertebral compression fractures. So with this patient population, we should really avoid excessive spinal flexion and rotation. It's noted that greater than 50% of patients with COPD have or are at risk for developing osteoporosis due to oral steroid therapy. So a large percentage of our patients with COPD have already or are at risk for osteoporosis. So making sure that we are taking maybe proactive steps to avoid excessive exercises with excessive spinal flexion and rotation. We probably have a lot of patients that are diabetic. Those patients need to, we need to make sure that we're educating those patients on how to manage both hyperglycemic and hypoglycemic events, that they are checking their blood glucoses, or we're checking their blood glucoses for them before and after exercise, to know and learn how their bodies respond to the exercise stimulus, making sure that we're educating on self-management and behavioral techniques, that they are performing self-check blood glucoses at home, and if it's available, teaming up with a diabetic educator. I don't have the privilege at my program to use leverage a diabetic educator. We don't have one at my hospital, but for those of you that do, team up with a diabetic educator. They can be extremely valuable in helping patients manage this difficult comorbidity. We'll have patients with osteoarthritis, so making sure that we're helping patients use or encouraging patients to use their walking aids, their mobility aids, and so they're not at high risk for having any adverse events due to their osteoarthritis while they're in their program or even out on their own. And we'll have post-surgical patients too. So we might see patients that are post-lung transplant. So they have median sternotomy precautions that they need to follow, patients that have had joint replacements, fractures, soft tissue injuries. We need to make sure that we're following whatever precautions the surgeon or physical therapy provide for us. So we could also see patients with peripheral vascular disease. We're seeing a lot more patients with peripheral vascular disease, actually. And so these patients may have difficulties achieving recommended intensity levels due to intermittent claudication and pain in their legs from their peripheral vascular disease. So making sure that we are accommodating these patients and adjusting exercise modalities and intensities to help these patients continue on in our programs. Our patients may suffer from depression and anxiety, which can have a huge impact on exercise adherence. And we should obviously be screening for these things pre-program and making appropriate referrals and providing education on how to manage the symptoms of depression and anxiety in our programs. Cachectic patients have a loss of muscle mass, so resistance training and education around increased caloric intake certainly should occur. for patients that are at risk or have or currently experiencing malnutrition. Patients have a wide variety of physical limitations, whether those are musculoskeletal, severe osteoarthritis, maybe they're neurological and due to a stroke or other neurological conditions. So making sure we're accommodating those physical limitations. Making sure that we're taking into consideration in our exercise program for the patient what their home environment is like. Remember, once they complete the program with us, we want them to continue exercising on their own. And so we need to consider what their if they plan to exercise at home, what their house is like, what their yards are like, how close are they in proximity to a fitness facility or to like a wellness program, a continuation program, whether they have stairs at home, whether they live alone, whether they live with family or in assisted living, whether they have equipment needs that need to be met, and making sure that we are setting up and having discussions with a patient about their home environment much sooner than before they complete our program, so that they are well prepared to exercise at home or outside, basically outside of our facility. Patients can have a variety of financial issues. I work in a rural healthcare program or a rural hospital program that the majority of our patients travel a good distance to get to us. So because of that, we have a lot of patients that are not able to get to us because of the distance. And if it's not because of the distance, it's because of the cost of gas makes that distance a tall ask for a patient to attend an in-person program. And if it's not due to the gas cost, it's due to the insurance cost, the copays. Copays can get really, really expensive. And of course, if patients are coming 36 times or more, then it can be a lot of financial barriers. So making sure we're doing whatever we can to assist patients in that area. I'm seeing a lot more patients in my program lately that need foreign language assistance. So aligning, setting up translator services for these patients as well. So these are just some of the accommodating factors we need to consider in our patient population. So one of the big things we experience with our patient population is oxyhemoglobin desaturation. We know that the goal is to maintain an SpO2 of 88 to 90% or higher in these patients. Not only certainly at rest, but when they're exercising. So we need to be sure that we are continuously or intermittent spot checking our patient's SpO2, making sure that we use supplemental oxygen on continuous flow. Every program is different. We use oxygen concentrators that we can increase up to 10 liters a minute for continuous flow oxygen delivery. But a lot of our patients may come in wanting to just stay on their concentrator that is pulsatile flow at a much lower flow rate or liters per minute. And so we find that when patients do that, they can become desaturated much more quickly. And if that happens, not only do we want to switch them to continuous flow, but we want to consider alternative oxygen delivery devices. So instead of just a nasal cannula, maybe this is where we bring in an oxy mask, a rebreather mask, high flow nasal cannula to make sure that we are keeping the patient's oxygen to a safe level. Of course, making sure that we have a good dyspnea management policy to manage, making sure that our staff are prepared to manage patients that have acute dyspnea emergencies. We can even consider our patients that have difficulty maintaining that saturation, pre-dosing them with their short-acting bronchodilator 15 or so minutes before their exercise session to help reduce some of that shortness of breath and oxygen desaturation. Of course, we should be encouraging pursed lip breathing in our patients with obstructive lung disease to help with the desaturation or to prevent desaturation, and encouraging good posture as well. So some additional things to consider in our patients that have exercise-induced bronchoconstriction. depending on what their triggers are. Everyone's triggers can be a little bit different, but certainly cold, dry air pollution, allergens, trichloramines in swimming pools, making sure that we are prepared or having educational conversations with our patients to help avoid some of those triggers, and successfully manage anytime they do have exercise-induced bronchoconstriction with short-acting bronchodilators, that they're prepared to handle those situations. We've already discussed timing medication, especially those short-acting bronchodilators, 15 or so minutes before they start activity. We want to make sure that we're doing activities with our patients that take into consideration what they enjoy, what they like. I try and encourage all my patients and educate all my patients on the importance of doing walking and treadmill exercise. But there are some patients where they just truly dislike the treadmill. They call it the dreadmill. And unfortunately, there's not a whole lot. I look at it like I can force them onto the treadmill. Or the alternative, probably the better option, the one that I typically choose, is I don't typically have that fight with them. I realize if they're getting an appropriate exercise intensity on a piece of aerobic equipment other than the treadmill, and for the right amount of time, then they can still receive the majority of the health benefits from their exercise, and they don't have to do the treadmill. Certainly, if I force them to do it every time they're in my facility, it's not, and they don't like it, they're probably not going to do it when they leave the facility. So trying to make sure that we are establishing appropriate exercise habits with our patients, trying to make it as enjoyable as possible, really increases the likelihood that they'll stick with it in the long term. So wrapping up with some training considerations for other diagnoses. So the first we're going to talk about is asthma. And unlike chronic bronchitis or emphysema, the symptoms of asthma are often reversible. There are not any current evidence-based guidelines for exercise training in patients with asthma, although certain recommendations do exist. And the first of which is to follow the FIT recommendations for exercise in healthy adults for patients with asthma, making sure that we are educating and developing, incorporating into our exercise prescriptions, the education around short-acting bronchodilators and leveraging those before exercise in these patients, making sure we're educating them to avoid environmental triggers, and just know that there is insufficient evidence to support a clinical benefit from inspiratory muscle training in individuals with asthma. And once again, that relates to the fact that individuals with asthma and asthma alone don't typically have inspiratory muscle weakness. There are other physiological limitations, airflow restriction limitations that are occurring that are not due to inspiratory muscle weakness. So it may not be the best use of your time to incorporate inspiratory muscle training for this population. Next is pulmonary arterial hypertension. So this is where a patient has pulmonary vascular bed impairment characterized by elevated pulmonary pressures. This causes fatigue, shortness of breath, muscle deconditioning, and syncope. Individuals with pulmonary arterial hypertension can experience sudden increases in pulmonary pressures during exercise, predisposing them to right ventricular decompensation and cardiovascular collapse. So we have to be very careful with our exercise intensity in this population. If you have the ability to, if you are a combination cardiac and pulmonary exercise program, consider using ECG monitoring to keep an eye out for any ventricular ectopy or bradyarrhythmias. I know not every program has the luxury of having ECG monitoring, and you still may be working with this patient, but if you do have that ability to consider using it. We certainly want to maintain our SpO2 with this patient population. It becomes very, very important because as an individual becomes hypoxemic, that can lead to further increases in pulmonary pressure. thus increases the risk of ventricular decompensation and sudden cardiovascular collapse. So the recommendation for exercise intensity in this population is, it could be a little bit confusing on here, is low intensity, but greater than or equal to 5 days a week for those that can tolerate it. The idea here is a lower intensity, more frequent exercise. So they're exercising more often, but at a lower intensity level, so the overall volume of exercise can still be achieved. It's just at a more frequent level and a less intense level. Making sure that we are educating these patients on pacing themselves, using energy conservation techniques. And just remember that high intensity exercise or activities that lead to intrathoracic pressure, increased intrathoracic pressure, such as interval training, heavy weightlifting, or any resistance exercise that elicits the Valsalva maneuver should absolutely be avoided. So resistance exercise using machine weights, bands, and tubes have been shown to be safe and effective for patients with pulmonary arterial hypertension. So we don't have to avoid resistance training with this patient population. We just need to be cautious. And when I say cautious, meaning we need to educate the patient on proper breathing techniques and avoiding the Valsalva maneuver and in general. Patients with interstitial lung disease. So this includes patients with pulmonary fibrosis, sarcoidosis, any drug-related pneumonitis, or any other really fibrotic lung condition. These patients have dry cough, exertional dyspnea, hypoxemia, and exercise intolerance. For this patient population, it's recommended that the patient follow the FIT recommendations for COPD. Moderate intensity aerobic exercise should comprise the core of this program. These patients can desaturate quickly and substantially. So making sure that we have the ability to deliver a high fraction of inspired oxygen or oxygen at a high FiO2 during exercise to avoid excessive reductions in SpO2 is critically important in this patient population. Patients with interstitial lung disease typically have low lung volumes and reduced diffusing capacity. So they'll often have rapid shallow breathing pattern. And because their diffusion capacity diminishes during exercise, these individuals often require supplemental oxygen and to a high degree, as we discussed. So cystic fibrosis is a genetic disease that affects the lungs and digestive system, where the body produces excessively thick, viscous mucus that clogs the lungs and obstructs the pancreas. Patients with CF often have cough, increased sputum production, shortness of breath, exercise intolerance, and decreased quality of life. There's no cure for CF, but regular exercise and increased physical activity have been shown to be beneficial for these patients. And we know that higher levels of physical fitness have been associated with better survival rates in patients with cystic fibrosis. So hence the benefit of a pulmonary rehab program for these individuals. These individuals can follow the FIT recommendations for COPD and making sure that we are prioritizing regular use of airway clearance techniques and infection control procedures in this population. But we are seeing patients with cystic fibrosis live significantly longer than they have in the past. So there is a decent chance that you might see some of these patients in your program. Finally, lung transplant patients. Exercise capacity is a very important predictor of thoracic surgery outcomes and survival. And increased exercise tolerance has the potential to improve surgical outcomes. So that's the importance of the pulmonary rehab program and a quality exercise program in this patient population. There currently are no evidence-based guidelines that exist for lung transplant patients, but the recommendation is that these patients should be exercising at a workload, at their highest tolerable workload, from a shortness of breath and fatigue standpoint. This is a population where interval training may be the preferred route of exercise for this group. Early post-op exercises should include range of motion, transfer activities, breathing pattern efficiency, and airway clearance education. Some of your programs will see patients very quickly after lung transplant. A lot of the programs out there won't see lung transplant patients until after they are a few months after they have completed those early post-op PT and exercise programs. Make sure you adhere to whatever institution-based post-lung transplant range of motion and resistance precautions that are given to you or get given to the patient. High-intensity aerobic or resistance exercises should be avoided 4 to 6 weeks. Post-transplant, to ensure proper incisional healing, the same precaution is adhered to with patients that receive median sternotomies for coronary artery bypass grafts. So just utilizing that is more of a median sternotomy precaution than specifically a lung transplant patient precaution. And that will do it. So I hope that this module provides is very educational and is very useful to you. I made sure to list all my references here, where all of this material comes from. A lot of the pieces here, the texts and the articles listed here are ones that are can be extremely valuable to your program. So thank you so much. I appreciate you having me.